So we're going to go ahead and talk about the suture tape augmentation and getting athletes back in the game. Let's see, how do we advance?
Put your cursor in the middle of the screen and click once. Get your green arrow in the middle of the screen.
Oh, there you go. Okay. So the goal here is to allow an athlete a quicker return to play while improving the short and long-term goals. And there is some science behind this. This is the study out of Tom Clanton's lab. He looked at the modified Brostrom through different means of fixation. And what they showed is that the load to failure was about 150 newtons for the intact ligament. And no matter which way you fix the Brostrom, your load to failure was somewhere between 50 and 70 newtons. And then Lou Schoen had this cadaveric study showing if we did not protect the ATFL repair, there was some elongation of that ligament that could lead to failure of our repair, and therefore suggested that we should immobilize our patients after surgery. And then Tom Clanton, in a secondary study, showed the suture tape augmentation was statistically significantly stronger than the Brostrom with anchors alone, and at least as strong and stiff as the native ATFL, giving us surgeons confidence that we can move these patients early. This is my current setup. I know Dr. Ferkel just said that he likes to re-prep and drape and all new instruments, but we've been doing this for years, where we just simply take out that leg holder, bring the leg down, have a bump under the hip, and we're ready to go, saving us probably 10 to 15 minutes in the surgical procedure. We'll then mark out our incision, and that incision now has gotten smaller with what we're going to show today in this talk, which is new instrumentation for the internal brace. We'll dissect down. I too, like the longitudinal incision as shown here, will peel the cuff back. This does afford you the opportunity to look at your perineal tendons. This is what is in the kit, and this instrument here is new, and that allows us to almost percutaneously put that tailor screw in. So we'll use these all suture anchors. These are fiber tack anchors through a 1.6 millimeter drill hole. We'll place 2 such anchors in the fibula. And then, as you can see in the bottom left here, we're using this guide that fits right in the sinus tarsi, has a little flange that goes right in there and fits nicely around the talus, and then you'll drill. It affords you the opportunity to really check a fluoroscopic image, making sure that that screw is not being placed into the subtalar joint. We'll then tap percutaneously and over the guide wire. And then this is very, very nice feature on this, on the swivel lock anchor. You can see this little window, and when that little window lines up and the line comes through, that means your screw is completely in the bone. So I think that helps avoid that proud screw. Once we're done, we'll repair our Brostrom in a standard fashion. I hold the foot in neutral with slight eversion, and then we'll place our 3.5 millimeter swivel lock, which is the second arm of the internal brace, and we're doing that here. And you can see this little hemostat underneath to get a reproducible amount of tension in that internal brace and avoid over tightening. This is our final construct. And just so happens I have a CT scan that we did on one of our patients with all the soft tissues pulled away. And this is really what the footprint should look like once you're done. My post-op protocol is a day of surgery. They get a splint or a cam boot. They'll return to the office at day 2 or 3. I'll then place them in a cam walking boot, allow weight bearing to tolerance. By week 3, end of week 3, they go into an ASO ankle brace with a regular shoe. By week 6, sport specific training. And by weeks 10 to 12, they're back out playing. This is a 5-week post-op, believe it or not, in a Division I diver. Insert performer here. You can see this guy's a little bit of an outlier. I mean, he does look a little better than the average Joe, but just shows you what we can achieve. And then if you watch this video, this is a BYU lacrosse player. You'll see him right here shoot on goal, number 36 there. And he returned himself to play at week 7. Not my guidance, but he did, and showed here at week 8 playing in a game. You can actually do so without problems. What are the outcomes? Coetzee published this paper, 81 patients. They had return to play at mean of 84 days. They have very few complications in their cohort. This is something I get asked, what about the generalized ligamentiously lax patient by Baton's criteria? 28 patients followed greater than 2 years. Only one patient had recurrent instability. And then this is our long-awaited study. It should be published here in the next month or two. It's been accepted at Foot and Ankle International. We had 119 patients with chronic lateral ankle instability. Primary outcome measure was return to pre-injury level of activity. What we showed was there's about a 4.2 week difference. So the results suggest that suture tape augmentation allows for earlier return to pre-injury level of activity than the modified brochum alone. So in this athlete that we're trying to get back out on the field, it makes sense to add in a suture tape augmentation. And secondarily, it may support successful accelerated rehabilitation, which we believe is paramount to good outcomes and quicker return to sport. So in conclusion, accelerated recovery and mobility is possible with the suture tape augmentation. It allows for an earlier return to activity, no need for casting, decreases postoperative pain, and the internal brace may protect from future injury. Future studies will tell. Thank you.